then we thought some details are, they require further description and all. That's why we decided today we'll keep it as a descriptive session, inshallah, and tomorrow we will do the mocks for different, scenarios that we will discuss today. So you guys are, better prepared for it, inshallah. So we will start Bismillah Rahman Rahim with the short stature. So whenever you will have a child with a short stature, how you will approach that child, okay? So what can be your command when the examiner he wants you to do the short stature sheet? The command would be generally physical examination, okay? So look at the child and do the relevant examination would be the command, okay? And of course, the child will be clearly short statured, so you can immediately pick it up. Inshallah, when we will discuss musculoskeletal, you will see that there will be some overlapping between the things that will be there, and we will discuss what you need to do when different commands are given. So first we'll just focus on short stature, okay? So whenever you have a child with a short stature, as you'll enter the room, again the same same scheme that you follow for all of your cases, that is 4DS. That is, you will look at the dimensions, any obvious disease, dysmorphism, any deformity, and any special surroundings and devices attached. Okay, so this will be the same approach as it is for all the cases. Okay, so you will start with these 4DS, and then you will, of course, see that the child is short. Okay, so you will, of course, when you will look at the child, you will know that the child is definitely short. Okay, so you will immediately ask the examiner that I would like to, plot him. I would like to take his height, and I would like to take his standing height, sitting height, arm span. Okay, and as well as I would like to, know the parental heights for this child. Okay, so these are the parameters that you have to mention straight away when you see a short child. Generally, the examiner will not ask you to do the parameters. Okay, if he asks, okay, you can do it, so you can say I will do it at the end of my examination. First I will do the relevant examination, okay, because these maneuvers, they will take time to be done. So generally the examiners are not asking also, but they are very important. If you don't mention them, then it will be considered definitely as a pass and fail criteria. If you don't mention that you want to take the different maneuvers of the height and the arms, and if you forget to mention about the mid parental height, again then it will also be a problem. Okay, so whenever you have
Sorry.
Yes, doctor.
Yes.
Ma'am, as we are starting the examination, so first we have to tell the examiner I would like to do his height. I would like to do the height of the patient, like
When you encounter a patient who's short, so you have to mention, na, because you encounter the patient who's short, so you will tell them that I would like to take the sitting height, standing height, arm span, and the mid parental height. So he will say, okay, you can do it in the end. Okay, then you will process, because that is what you identified, that this is a short stature, and your command is also look at this child and do whatever what you feel is relevant. So the relevant finding was short. Similarly, if the child is tall, then you will also say like this, okay? Because what is that? This is a structure of examination. But since the time is short, that's why you don't have to take these measures. Sometimes you have to take the measures that we will tell you how to plot on the graph and all those things. But in the short clinical,
but
time is less.
ma'am, the upper segment and lower segment ratio here is the important. So the examiner will say is that leave it for the end.
It will be a part of discussion, then how will you measure, or it may
Oh,
you are not able to demonstrate that because this 5 minutes, if then it will be only you can do only the upper segment, lower segment height and all this. So usually it's not, but it is the
okay.
part of discussion. Why, which short stature is associated with low upper segment, which is associated with low upper segment. Okay, this is a part of discussion. That's why somewhere these points will be covered.
Okay, that
Sometimes it
means we
is
have
in
to just offer
huge
him
patient.
that I would like to do the height of the patient.
Exactly.
Okay, okay.
So that is how you're going to start. And once you see that, the child is, short, then you have to do certain maneuvers, okay? To see, to pick up certain syndromes and to pick up certain maneuvers. Okay, so these are the maneuvers the doctor has already discussed. So when you have a child who is clearly short, you will of course ask the child to stand up. You'll expose him appropriately, okay? Scan him from the front, from the sides, from the back, okay? So pick up if there's any obvious dysmorphism, any other problem, okay? Maybe you can ask him to, walk a bit, okay? And then you do different, the maneuvers. So first will be, you will ask him to bend forward, okay? And bend forward as in, you can even ask him to, touch the floor if he can, okay? At this point, you will see the spine, okay, and you will check the legs, okay? There could be any kyphosis, scoliosis, there could be any other deformity, okay? So bending forward, the other one will be you will ask the child to stand straight and stretch the arms in front of you, okay, to look at any limb asymmetry that can be found in short stature would be Russell Silver, okay? But if a tall stature with the limb asymmetry is there, then it could be Beckwith Weidman. Okay. So you will ask the child to stretch the arms in front of you so you can look for any, asymmetry of the hands. Okay. Then you will ask him to make a fist. Okay. He will make a fist and you will see the fist. Okay. When you will see the fist, what you are looking at, you're looking at the short metacarpals, any syndactyly, okay, any polydactyly, any hyperconvex nails, okay. So you're looking at all these short fourth, fifth metacarpals, okay. So you're looking at all these findings, okay. Then you will ask him to make a star, as in you'll ask him to open the fingers widely and showing the hands, okay. In this one, you will look for any trident hands, okay, small fingers, okay, short chubby hands, any abnormal palmar creases, okay. So that is what you're looking for, okay. Then the fifth maneuver would be, you will ask the child to, stand with arms beside his trunk, okay. This way you are checking his carrying angle as well, and you are seeing where the hands are coming in proportion to his legs, okay. Are they coming in the mid thigh? Normally a normal person's hands will reach the mid thigh. So maybe it is, short, longer, whatever it is. So you can, comment on it. So you can, pick up either it's a rhizomelic, mesomelic, or an acromelic shortening of the hands, okay? Or even the legs also can have the same, okay? So I believe all of you are aware of rhizomelic, mesomelic, and acromelic shortening. So rhizo means root. So proximal part is the rhizomelic shortening, that is shortening of the humerus, and the femur is called rhizomelic shortening. Mesomelic will be the radius and ulna and tibia and fibula. And acromelic will be the extremities, that is the hands will be short, like in achondroplasia, okay, MPS. Okay, so these will be so this will give you a clues as to what kind of a short stature you're looking at and what different, differentials you can make, okay. And then the last menu will be to touch the shoulder with the thumb, okay. This is again to check for the limb shortening, okay. So these are maneuvers, they carry marks, okay. So whenever you see a child with short stature, after you do your 4DS, scan the patient from front to back, ask him to bend forward, then to stand straight, okay. Look at the outstretched hands for any limb asymmetry, ask him to make a fist, ask him to make, star, okay. Then he can leave his hands besides his, trunk to look where the length of the hands are reaching, and also to look at the carrying angle. And then you will ask him to, touch the shoulders with the thumb to look for rhizomelic, mesomelic, or acromelic shortening. So these are the maneuvers that you will do. Generally, don't mention it that I'm doing maneuvers for short stature, okay. Some examiners, they don't like this term, okay, when we use it. So just when you see short stature, after you know that, this child is clearly short, you will ask for the different measurements, okay, and then you will do these maneuvers before moving on to your general physical examination, okay. Is it
It
clear
is
till
just
here?
to help you to find out, to identify, because these are the things, so you will not forget what you have to look in the back, what you have to look in the hand, because these are the findings in which you can pick up the case within the 1 minute, because the way you approach the patient and then what you did, the short stature along with these things. So that is a kind of a mnemonic to remember you that these are the 5, 6 signs you have to check before starting again.
Okay, and then physically also when you're looking at the child, you can tell whether it's a proportionate short stature or disproportionate short stature. And then there are different causes to each of these. Okay, what are the different causes of a disproportionate short stature? That would be generally the skeletal dysplasias like achondroplasia, hypochondroplasias. Sometimes rickets can cause, disproportionate short stature. Okay. Proportionate short stature generally you see in different kind of syndromes, in, chronic illnesses. Okay. Nutritional deficiencies. Okay. So these are the different causes of proportionate and disproportionate short stature. So when you clearly see that this is a disproportionate short stature, then you can, go on to the differentials of disproportionate short stature. Okay. Okay. Then after you have done this, okay, then again you will, you can start your hands you have already seen for this child. Okay. So then you can come to the face. In the face, you will look for any specific, dysmorphic features. There are a lot of syndromes that are associated with short stature, like Down syndrome, Russell Silver, Noonan's, Turner's. Okay. And you all are aware of the physical features that are present. So make sure you're looking at the, eyes for any ptosis, epicanthal folds, cataracts, clouding of cornea. For example, in MPS can also come in a short stature scenario. Okay. You have to look for any hearing aids that are there. Okay. You have to look for high arched palate, any protruding tongue. Okay. Uh, you have to look for any other features like Russell Silver. They have a triangular face. They have, downward slanting eyes. So you need to know the features of each syndrome that might be coming in short stature. Okay. We will discuss them individually. We'll touch on them, just briefly, but you need to know them. Okay. Then when you will come on to the neck, you will look at, short neck, webbed neck, low hairline, springal deformity that can be there in, Russell Silver. Then you will look at any mass in the neck, because hypothyroidism itself can present as short stature. Okay. So you will see all of the things. Then coming to the chest, important finding will be any chest
One
deformities.
important thing I will add, like in some countries, there is a culture of covering. So don't tell to remove it like from the head, but just like if I would like to see the neck, so they will just like little bit of neck you are able to view. Okay, so if somebody's short stature and they are covering the head, something like that, so don't forget the neck. Ask them to, can I am I able, or is it okay? I want to look at the neck also, because a thyroid swelling you don't have to miss in short and tall stature, anything. So neck examination is important.
Exactly, webbing of the neck, low hairline. So they're very important features that might be hidden, and the examiner might give you the answer. Yes, he has a web neck. She has a web neck. You can continue further. No need to expose. Okay, of course, especially when you are in UAE and you are in Pakistan, things are different. So you have to, of course, take into consideration these things. Okay, then when you'll come to the chest, you have to look for any deformities, chest deformities. For example, what kind of chest deformities can be there? In hypochondroplasia, achondroplasia, definitive MPS, all have deformed chests. Okay. In syndromes, you have to look for white space nipples. Okay. So these are important things. Okay, on the chest. Then when you will come to the abdomen, you will, of course, look at, rickets also will have findings on the chest. When you'll come to the abdomen, you look at pot belly, Harrison sulcus, any umbilical hernias. Okay. Any, scars, striae. Okay. You have to palpate for the hepatosplenomegaly in general, but that will be a quick one, not any detailed one. Okay. For example, if a massive liver or massive spleen is there, you'll be able to palpate it quickly. Maybe a quick nephromegaly if the symptoms are very obvious for, storage disorder. Okay. You will look at the hernial orifices, look at the genitalia. Okay. Make sure you're not missing the genitalia, because in short stature, there can be issues. Short stature, tall stature, obesity, genitalia is a pass and fail criteria. Don't forget it. If you are not doing it, ask the examiner that I would like to look at the genitalia for any cryptorchidism that can be found in Noonans, okay? Or maybe could be something else also, because in Down syndrome there are chances of tumors, malignancies. So you have to mention the genitalias for sure, okay? And then when you'll come to the legs, you look at any same rhizomelic, mesomelic, acromelic shortenings, uh, any scars, any deformities, okay? So that is how you will conclude your examination of a short stature. Then in order to continue in this one would definitely be, you would like to do the pubertal assessment of these children, okay? And also the nutritional assessment, okay? Because the short stature could be because of nutritional deficiencies as well. And puberty is extremely important, because a child might be appearing underage to you, but his age might be very different, because we know there are certain syndromes, and when the height is short, generally they appear younger for their ages. So make sure you do the pubertal assessment, okay? And you also comment on the nutritional status of the child, okay? So that is extremely important. And if you feel that this is a syndromic case, please mention that I would like to do a detailed developmental assessment with hearing, vision, whatever is relevant to your case, okay? So that would be the thing, okay? As I mentioned earlier, command can be general examination of the child if the child is short, or in MSK they could be different, okay? So when we'll go to MSK, we will discuss what commands can be given for a short child in an MSK station, and in that one you have to follow the MSK pattern, not the short stature pattern, okay? Right now we are focusing on the short stature pattern, okay? Now let's quickly discuss what are the different causes of short stature. What is the definition of short stature? Anybody can tell? Because these are going to be the discussion questions now, okay? So you've done your examination, so the examiner is going to put up some questions for you, okay? So can anybody tell?
Less than second centile, or crossing 2 centiles in a span of
Two. Okay, it's simple. Less than the second centile or more than 2 standard deviation will be a short stature, okay? Now what are the different types of
For the
short
age
stature?
and sex also, okay?
Yes,
Okay.
exactly, for the age and sex, that is very important. And for different syndromes you have different charts also, okay? So if you have clearly the child is syndromic, for example Down's Turner, there will be different growth charts for them. So you will say I would plot him on a relevant growth chart according to his condition and according to his age and sex, okay? Then the short stature are generally of two types. One is a physiological, or you can say a constitutional short stature, and the other one is pathological short stature. Yes, in short stature you also have to ask for serial growth charts that I forgot to mention, so please mention that as well. I want to know the growth velocity of this child, okay? So that is also extremely important. So when you're asking that, I would like to know the standing height, sitting height, arm span, parental height, and I would also like to have serial assessment of his growth charts to know his growth velocity, okay? That is extremely important, because growth velocity is the one parameter that differentiates between the pathological short stature and the physiological short stature, okay? So what is the difference between both of these? Anybody can tell quickly?
which one? Constitutional?
And familial.
Yeah, familial means final height.
Logical.
Familial short stature, or will be the final adult height will be less, because the parent genetic potential is less. So the born age will be equal to the chronological age
Okay.
in familial. In
Family.
constitutional, the final adult height will be normal, but the present age, present height will be less for the chronological age. But when we check the born age, it will be less.
Excellent. Okay. And these are all the normal variant of short stature. Familial and constitutional short stature are called the normal variant short statures. Okay. In both of these, the height will be below third centile, but their growth velocity will be optimal. Generally, what is the normal growth velocity in any child? It is around 5 centimeters per year. So when you will see their growth chart, they'll be growing 5 centimeter each year. Okay. But in spite of that, they are short for their, peers. Okay. So if the growth velocity is okay, but the height is less than second centile, this is called a normal variant short stature. And this will include either constitutional or familial. And as Dr. Jasmine mentioned, what will be the difference? Familial will be the family will be short, the parents will be short, and the bone age and the chronological age will be equal. Whereas in constitutional short stature, the parents are tall. They will have a history of being late bloomers. Okay, they will tell they were also short. They were also, mocked or bullied for short height when they were the same age, but then they grew very well later. And then the bone age will be less than the chronological age, which means that the bone still has the potential to grow. Okay. So that is
So
the
actually,
important.
at this time, that is why the mid-parental height is important, okay? Because mid-parental height, if they will fall within the range of mid-parental height, that means they are familial or constitutional short stature. If they are falling even below the mid-parental height, the norms of the mid-parental height, it means that's a pathological stature. And the other differentiating point is the bone age, between the familial and constitutional short stature. And also it can be a question for you guys also, if you are taking history or maybe in this short stature, like what else you would like to ask in constitutional short stature. So this is like the parents will be late bloomers, so means like their height velocity and the height is increased after puberty, and in the familial one it was short also, the parents also didn't. So the late bloomers question was important to differentiate between familial and constitutional short stature. And if the parents are in the room, in the familial, the parents are also short, but in the constitutional, they will be of the adult, final adult height will be normal.
Exactly.
So this is a concept that is a little bit maybe because the familial and constitutional short stature, and that's why we are talking about the mid-parental height when we see a short stature child. Is it a physiological or pathological short stature? So in the beginning, the dimension of mid-parental height is very important. The other thing is about growth velocity, because what we are discussing is short stature that is less than the second centile. But if the growth velocity is any time coming, like you are checking the previous growth charts and it's dropping, it's coming one centile down. So that is also another definition which leads to a pathological cause. Okay. So there is like not just one definition, but at least we should know what is growth velocity, and it is a red flag if its growth velocity is going even one centile down. But for the definition purpose, this is the definition for short stature, less than the second centile or 2 standard deviation below the mean for the age and sex of the child.
Okay, excellent. Okay. And then coming to the causes of pathological short stature, what are the different causes of pathological short stature?
They could be because of some syndromes,
Mm-hmm. Excellent.
endocrine problems, or some skeletal dysplasias.
Excellent. It could be iatrogenic because of steroid use. Okay. It could be because of nutritional or nurturing deprivation. And then sometimes it could be idiopathic also. So you should have a broad, idea of the different, areas that can be affected, leading to pathological short stature. Okay. And then coming to the upper segment, lower segment ratio, anybody has any idea what is the significance of that, and how do we take the upper segment, lower segment ratio? Generally, for upper segment, generally when we are taking height, we take the the entire height of the child. Make sure that the occiput is touching the wall, the shoulders are touching the wall. Okay, the buttocks are touching the wall, and the heel are also touching the wall. That is how the child should be properly aligned with the wall when you are taking the height. Okay. So when you've taken the total height, you can either ask the child to sit down, okay, or you can, the lower segment height can also be taken, the height, the length from the pubic symphysis to the heel. That is the lower segment height, okay? And then you can subtract the lower segment from the total height. It will give you the upper segment height. Okay, so these are different ways in which you can, measure the heights, okay? And what are the different reasons of, changes in this ratio?
Actually,
Normally,
we are taking the upper seg.
No, it's the usually you can take any of them, but mostly lower segment is more lower segment is more easier and appropriate that you take the lower segment.
While sitting, the upper segment will be taken. No, while standing, I think
yeah.
lower
Yeah,
segment.
so that child is standing now. You are taking the full height. So he's just
Yeah,
already standing. So at the same
yeah,
time,
yeah.
you can check it the lower segment. Instead of that, you can just put a sheet beneath, and then you can ask to sit the child on that sheet, and then you will measure it. So it will be little inconvenient. So the easiest was lower segment. Mostly that's recommended. You take the
While
lower
standing.
segment. Yeah, while standing.
Yeah, yeah,
Yes.
yeah. I was thinking sitting. Okay, okay.
No. When you are taking the full height from head to heel, then the same time you can take the lower segment height and then you will subtract
Okay,
and
okay.
get it.
Okay, okay. Okay.
Okay.
And Ishmaela, can you open that slide where you have mentioned about these ratios?
Yeah, I mentioned it somewhere. Maybe let me see. Anybody can tell us what about the upper segment and lower
It was
segment?
in the
Anybody can recall?
At birth, it is up 1.7 is to 1. Then by 3 years, 1.3 is to 1. Then at by 7 to 8 years, I think 1 is to 1.
1:1,
One is
exactly.
to
And in
one.
adult age, like when we're like adolescents, it will be like little more,
So
like upper
what
segment.
is this happening is like disproportionate and proportionate short stature. So proportionate short stature is upper segment and lower segment are equal. Okay, so there are just syndromes like Turner, Noonan. Are you able to see the screen, right? So Turner, Noonan, Williams, they are proportionate. And in cases of disproportionate, it can be a short trunk. So the upper segment will be less than the lower segment, like MPS. In the other one, the upper segment is more than the lower segment, then there will be short limbs like rickets or achondroplasia or osteogenesis imperfecta. These are the examples of disproportionate short stature. So that is what is the general few things that is like upper segment, lower segment, familiar and constitutional short stature. Now what we will do is like we will move on to this like what are the examples, the important short stature cases that comes in the exam. Till now, any question from anyone? Anyone wants to ask anything? Have you guys gone through this, the short stature? Some of the cases you have gone through? I've read something.
Yes, yes.
Okay, good. And are you familiar with how to plot that? Because today we will not show.
Yeah.
Inshallah, tomorrow morning we will share the growth charts and we will share the how you will plot it on the growth chart, the short stature, and how will you compare the mid-parental height. Are you guys familiar with the mid-parental height and adult height predictor chart?
Yes, yes. I do in OPD actually.
Okay,
Yes.
okay, that's good. Then it will be easier because it's just like for the first time, if somebody is not doing it's little bit, and there are the BMI charts also. Anyways, tomorrow, inshallah, we will show all those charts and we will practice a bit also. So this meeting session is just 2 minutes left. What I will do, I will send you a new link in 5 minutes. Then we will start with our cases, few cases important which we have added in our presentation. We will record these presentations and you can listen to them again or make your notes because there are some points in which mark it's not there in the mark. So you can add those additional points. They are very important as they are from the exam questions also that are being asked in discussion. So all the cases which we are discussing in short stature, tall stature, thyroid, there are few points other than mark. So you can watch these recordings again and just write it down. Please make notes of it so that it will be helpful for you. And otherwise, if you know everything, it's well and good. And if there is some additional point, do remember that. Okay, so inshallah, I will share another link and we will continue from the first short stature case.